Thank you very much. I'm very excited to have the opportunity to chat with you. I have a presentation which I'm not 100% sure if it has made it to the right places, but I have it here and I was just gonna play it through my screen.
Well, at least I can see you. And
so let's see if this works. Can you see my screen now?
We see the video. You like it's a video?
It's trying to come out.
Yes. Yes, we can see it.
Okay, excellent. So I'm going to let it take. I'm going to let the video speak for me, and at the end, I can answer any questions anybody might have.
For the Society for Simulation Healthcare, and I'm very pleased to have an opportunity to chat with you today a little about how SSH has played a part in utilizing for the needs of our community practice during these very difficult times. I'm an associate professor at the University of San Francisco, and I've been an accreditation reviewer for SSH for over a decade. I'm one of the editors for Defining Excellence in Healthcare Simulation Programs, and I've been heavily involved with SSH for many, many years, as many of you also have been. And for that, the organization is very appreciative of. So just a quick overview, the mission of SSH is to serve our members by fostering education, professional development, and the advancement of research and innovation. We are here to promote the profession of healthcare sim through standards and ethics, and we are out there championing healthcare simulation through advocacy efforts, sharing, facilitating, and collaborating. And no other time has it been more important during these last couple of years. And the purpose of the society is to serve a global community practice to enhance the quality of healthcare. So some of the areas that SSH has been focusing on, as hopefully you all are aware of, we have sections, interest groups, and affinity groups. In particular, the affinity groups are those that we are seeing a great number of individuals get involved. And the beauty of those is you don't have to be a member of SSH, but you can join and connect with others through the affinity groups and elements of our Sim Connect environment, which people find very helpful and have been very important during these difficult times. Some of our collaborative efforts, in particular accreditation, we have done incredible work linking organizations that are seeking accreditation to have mentorship from already established programs. You know, certification has grown tremendously over the years, and more programs are having an expectation that those who join the organization get certified either as an SE or an SOS within just a couple of years of joining. As you know, we have a journal. Like I said, the certifications we have are the SE and the SOS. We also have the advanced levels. We have IMSH, which is coming up soon, SimOps, and many courses free or need to be paid for that have made a huge difference during these difficult times. As a member of the board, it's a great opportunity for you to network globally. There's chair positions, executive leadership opportunities, and of course, innovation technology, which is really the middle name of SSH. So a little bit, you know, we've all been living this the last almost 2 years. So it was very clear that when COVID was showing that it was not going away, and it was determined that it was a pandemic, healthcare simulation programs were already gearing up, as they had done in previous periods with Ebola and other outbreaks, SARS, you know, the donning and doffing. You know, healthcare simulation really had an opportunity to show what it can do to improve outcomes for staff in preparing for taking care of this very challenging population. You know, we were at the forefront of providing mass education to healthcare providers. You know, SSH leadership, we quickly realized that our members needed just-in-time information and put out a web page on our SSIH website, which was free. What we were really trying to do was get the word out that we had resources and that we could be a hub for this information to be disseminated. We had experts throughout the field providing examples of best practices, and I'd say we were pivoting, which is just kind of what we do in healthcare simulation. So these are just just a couple of snapshots from the SSH web page that we put out and built upon over the course of the last almost 2 years, to give people opportunities to go to one place and get the information they were seeking, so they could easily provide education that was so needed as we pivoted from in-person to an online environment in most countries, and in some situations are still doing it a great deal. Social media, and there's a piece here about how to connect on our SimConnect website for affinity groups. We also had a lot of information about how individuals could utilize and should utilize PPE. And so they were donning and doffing videos from all different organizations across the world as we were trying to get our arms around how to best provide the support needed during the initial outbreak and throughout the pandemic. So it's been very clear to those in healthcare that simulation was a modality that would be able to fulfill an incredible void that was needed to assist learners to matriculate to their educational programs. And for established, residencies, schools of nursing, all the disciplines, they all had to quickly shelter in place and then pivot to an online environment. And we were incredibly fortunate that we had access to great systems such as Zoom and what have you. It wasn't the same as in person, but it did give us an opportunity as a community of practice to be able to then provide the support and provide mechanisms by which students could still matriculate and be successful in their pursuit of licensure. And in many countries expanded the ability to count simulation hours for the development of the clinical skills and thereby showing their competency. So I was involved with a group that was formed during this period of time. It was through the Inspire IPPS group, and a group came together that has evolved into what we call now the Healthcare Distance Simulation Collaborative. And I want to give you a little bit of information about this work. It was under the leadership of many people, but in particular Isabel Groth. There was a distance simulation summit, a taxonomy group, and a scoping review team formed this collaborative. And it was Todd Chang, who was in charge of heading up a taxonomy group, to help us understand and define distance simulation. Started talking about what we were trying to do and the way we need to present it. And it started this whole body of work that I want to share with you. So it was a collaborative. We reached out to many of the different affiliates to garner their support in disseminating our survey, which was, we had over 25 groups that volunteered to help us in this. We had a team, we had a core research team that met weekly to do the research, and we also have a steering group who helped guide the development, dissemination, and analysis of the work. I was part of this, the core research group, and it was just a dynamic team that was very interested in asking the right questions to get some information about how COVID was really affecting what's going on in healthcare simulation. What the survey group did was we were going through the IRB process, trying to figure out, well, what is it we actually want to know? And in that process, we came up with essentially a research agenda. Phase 1 is getting a snapshot of what it looks like. Phase 2 is how can we best inform educators? And that's the next step. And then phase 3 is what the hot question for all of us is, what we want to really explore at the end of the day is what is it as effective as in-person education? So in our development process, we had a survey development team. The survey was developed by a core group of 8 experts in healthcare simulation research and practice, identified by their leading roles within the healthcare simulation community. The group also included 2 experts in survey design. And our literature review was conducted by the core research group and via scoping review team within our larger group before developing the survey to ensure that our survey aligned with prior research in the area. The identification of key principles, we held several discussions amongst the research team to identify the aspects of distance simulation that would best answer the research question and identify several key themes to explore in the survey. Subsequently, the core research team broke into smaller groups to delineate specific types of questions and topics that would explore each of these themes. And we then had a development of survey items. An expert in survey design on the core research team took the work done in the previous steps and developed the specific survey items and inputted them into a Qualtrics survey software tool. We had expert validation. The core research group reviewed all the survey items for clarity and to ensure that they accurately reflected the concepts identified as important to explore in the survey. We did some pilot testing. The survey was sent to a group of pilot testers from the target population who were recruited by the survey team. These pilot testers were deliberately recruited from multiple countries and roles within simulation education. The pilot testers provided feedback on the survey via an email, and this was incorporated into further edits. The final survey was 44 questions long and estimated to take about 15 minutes to complete. So we had simultaneous efforts. You can see we had some taxonomy going on, addendums to the SSH dictionary nomenclature, Delphi census, we had a consensus on the terminology, we had a scoping review, an extensive systematic review of the literature, a pictogram looking at ways to present distance sim methodologies, and then a survey of distance sim, including unpublished work. So our findings of our survey, which a lot of people were very interested in. So to begin in terms of the product sample distribution, so overall, in terms of the analysis that we were presenting, the overall sample size was 618. In terms of the raw data that were actually collected, we actually reached slightly over 700. But because of missing data, some people came in, and they looked at the first question, so they stopped and what such forth. We actually decided to drop about 5% for the respondents, which is about 12.7%. So it gets us from 708 to the 618 that you see here. So most of the analysis, particularly some of the highlighted analyses, are based on 618, but also mention some of the others because people did skip through. It's not going to be at the 600 level. There's going to be some fluctuation in some sample sizes. So I just want to make that point up front. So, there were survey responses across 7 different languages, and the median and in terms of survey time, because that is a skewed distribution, was around 9 minutes. But it goes on for some people took a long time, and others took a lot shorter time. It said so our total, like I said, our total responses analysis was 618 in our survey times, whereas I noted. In terms of the respondents were so across 32 countries, and then within the United States, 44 states. And I know we'll spend a little bit more time in terms of responding characteristics later on, but the people who dedicated in terms of the simulation, about 50% or 40 or less than half the time, and then 60%, somewhere between 50 and 75% of the time. And then 41% of the respondents spent the majority of their time, 75% or more in simulation. And then in the bottom, you'll see the breakdown of the different roles of the people that responded. So of course, not all of it will add up to 100 because people added multiple roles. And in terms of educators, we had about 65%, and some of the other items here, but asked whether or not some of them were at the directorship or administrator level. So we combined all that, which is about 45% here. You see highlighted at the bottom of the slide. So one of the key questions that we asked was whether whether they've shifted you or not from distance simulation and whether or not people converted to distance simulation following COVID-19. So you see up there, statistical simulation activities prior to COVID-19 was around 28%. And that went up significantly, as you can see here, to about 70%. So you know that if you're running some statistical analysis, you can easily find that a significant improvement is there. And we'll next find out some of the nuances. Areas that went up and down in terms of folks who are actually conducting it. We're currently conducting about 60% distance simulation in those organizations. And it was the first time they really used it. And then for folks who were using distance simulation previously, about 7% stopped using this, which I thought was a very interesting dimension as well. So, oops, there we go, next slide. Apologize. So the questions we were asking about how and whether or not people were thinking about continuing on moving forward, you could see that between March and May of 2020, we were about 50%, and then September, November of 2020, we went up to 55%. In hybrid and in-person increased from 16 to 40%, and in-person simulation has increased somewhat, and long-term plan to go hybrid is 82%, which is quite significant. So we also asked what kind of factors have prompted organizations to develop student sims. So you know that what are some of the things that motivate them to develop this. So they've highlighted here in the top 3 factors, which were access to technology, access to personnel, and interest in simulation instructors. So you know the fact that they have to have access to technology and access to personnel, then there's interest in simulation instructors, were all that drove people to develop distance simulation. So you know, directors and so forth, these results seem to be consistent regardless of the roles, but it seemed like there are needed to have some form of infrastructure as well as personnel and educators to really begin rolling this out. So I think that might be something important to mention. So participant locations, we looked at where they were happening, where they're administered, and where participants were. So we were looking at procedural simulation, so that's where happening, and there's a lot of numbers here, but just to highlight some of the different trends, you know, if we look at different participant groups, at least for the procedural simulation, it seems like it's still happening in person than being online. And you'll see a majority of whether you're a learner, instructor, so on and so forth, that this is still happening in person rather than being in any other modality online. So that's sort of showing the highlights of that. So we moved from procedural now to clinical event based or team-based simulation. And now you see that right now you are seeing a little bit more of the online presence here. So not only were we looking at within in person, the separated and also the non-separated, but the synchronous online interactions begins to see a much heavier modality when it begins, being the clinical veteran team-based simulation. So then we've got our standardized participants, we're looking at here. Contrast that data with the simulated patient settings. So here in the simulated patient settings, it's interesting that you see now, you can see not separated versus synchronized. Depends the difference on where the learning is occurring, which does make sense. So we were asking questions about reasons for developing simulation at your center during the pandemic. You know, early we looked at factors, and now we're looking at the reasons. And the predominant reason was being from the center leadership, about 70 or 50% of the respondents said, that this is something, so leadership is very important. When you restrict the respondents just to the directors or administrators, is actually going to go up to 80%. So leadership is also an important piece. So our objectives and transition from distance simulation during the COVID pandemic, we asked 3 different prompts. Are you continuing the things that you're offering prior? Are you basically doing the same activities, which seems to be the highest? And it was just, like I said, it was just very interesting how continuing their existing simulation offerings was going to be, was still going to be happening. So we look at distance simulation. It's a bit of a busy slide, but still break down that for the first part and the second part of the talk. So what is sort of your long-term plan? And that is, as you can see, that they're going to be continuing sim, new distance sim, and continuing what they've been doing since COVID and maintaining a hybrid. But which is great because it looks like it's a very important way people see that there's a lot of value in it. So if you, oh, sorry, I keep jumping forward. There we go, sorry. So we have here, just so under 50% is where we see education for this, right? And simulation that's actually happening. And a bit lower simulation text, which is about 32%. So perceived satisfaction of the simulation center. The top 3 groups expects the highest level of satisfaction with leaders, the educators, as well as organizational leaders. But they kind of rank down here. And then we have our p-values. And then we restrict this question just to the simulation directors, what we perceived as the most beneficial. They actually were very happy from a leadership perspective and about 12% greater than what you might see here. Just a slight difference in terms of those respondents as well. So then we're looking here, types of simulations that were currently done. Types of simulation. So the type of simulations offered using simulations. So there's, of course, a whole lot of variety of different offerings, but in terms of the top, I'd say the top 5 is highlighted here. The highest being, orientation and competency training, and that's basic training tasks and continuing ed. It was quite interesting what sessions of utilizing it for. So limitations and challenges. The open survey design means that we cannot calculate the response rate because we don't know the denominator for the population that accesses the survey. However, administering the survey in this way allowed us to reach respondents that may not have otherwise had access to the survey. It is also possible that the relatively significant time commitment required to complete the survey may have led to systematically fewer responses from members of the simulation community who are busier with simulation or clinical work, evidenced by the fact that 12.5% opened the survey but did not complete it in any meaningful way. So in order to protect respondents' privacy, we made all questions on the survey optional, except for the first 2 noted earlier. This meant that some respondents did not have to answer all the questions. This is particularly relevant for demographic questions where we could not always decipher how many respondents came from an individual institution. This may have led to a non-response, to item non-response error. So what factors or issues do you think have driven a rapid engagement with distance simulation? In addition to the stats results, we also asked a specific question for people to articulate a little bit more about where their drivers were so that the driving factors behind what they're kind of pushing them towards a distance simulation. So I guess we want to pose a question to you. What kinds of things do you feel like have driven the rapid engagement with distance simulation? And people can maybe put some notes in the chat if you want. That would be great. But it's just, like I said, it's just something that we were curious about. So some of the qualitative data that were the open text, these are some of the things that we found were some of the drivers. So regulations in so many places were some form of lockdown, where we're working to reduce capacity. It could also be social distancing requirements or reduced capacity requirements for the institution. So that was a very common driver that we just couldn't do face-to-face. As someone mentioned, there was also some missed opportunities because of the urgency of things needed to be done like yesterday. Those are just some of the drivers we got from the open-ended questions. So here we've got, are the questionnaire regarded on modalities, specifically what kinds of the simulations do participants and how they do it. We collected 291 answers. The majority of procedural and mannequin simulations do not take place remotely, while standardized patient simulations and software simulations were more widely used remotely. Note that the software simulations of virtual reality are not used by 33 and 50% of the respondents. This one, when we wanted to compare experiences of preparation and realization that this is simulation by comparing with in-person simulation. Overall, the educational aspects of simulation are more difficult with distance simulation, as we can see on the predominantly darker bars on this graph. But not only teaching, but also for the development of simulation development sessions. Simulations follow a structure that we have summarized in 3 stages: pre-briefing, the simulation, and debriefing. Unlike the educational aspects, we found more variability in the answers, analyzing the ability to carry out the 3 stages of simulation as described above. The distance pre-briefing is not more challenging for 62% of the respondents, while the distance simulation is more challenging for 67%. So, the last questions had to do with the location of different people needed for the simulation. We chose 3 types of simulation: procedure, team-based, and simulation with standardized participation. Standardized participants. For the clarity of the results, percentages of answers for the active learner category is written on top of it. For procedure simulations, active learners and instructors are present at the sim centers, as you can see here. So, some more data. Oh. So how are the simulations technicians and educators prepared for distance simulation, if at all? And how imperative is training? Surprisingly, question 15 and 16 were not statistically significant for training, care session development, or training prior to teaching. It's as if people were just thrown into the distance sim world and winging it for the most part. This is concerning in that we know as an effective method are being used and if teaching is being received as planned. This likely has greater impact on learners or overall patient outcomes. Could this be a curriculum training that is developed, disseminated by a sim work? Potentially. What topics need to be covered for adequate training and how do we ensure it? This was question 18 and 19. Interesting in the fact that 31% were trained for developing distance sim sessions, and this was statistically significant. However, more than 2/3 were not, which is very surprising. Again, did places just wing it or figure it out as they went along? And are there plans to promote training to make distance sim more seamless? So more training was placed on technicians versus faculty educators. It's an interesting finding. The training environment. If we bend over the condition that fostered distance simulation, whereas to continue or to start at the occasion of the COVID-19 pandemic, we observe that access to technology and human resources are an essential element. The knowledge of the necessary resources is a critical point to help spread development and improvement of distance simulation. This, with the support of instructors, organizations, and programs, is probably what they should convey learners and undecided staff to move us all forward. Knowing how resources are important to implement distance simulation, a blind sort of a blind spot still. At what point does the lack of technical and or human resources may prevent or slow distance simulation to happen? So some of the instructors volunteered for distance simulations. Others were chosen by leadership or had to convert because of their assignment as faculty. Uncertainty and lack of preparation may scare instructors off. It is likely that training may help in facilitating and reassuring staff. Training characteristics. Even if results are better in pre-existing distance simulation programs, educators and simulation technicians were not enough to undergo a specific training, and among those, hardly 50% got it prior to distance simulation. We couldn't imagine that the training would have been more developed in new distance simulation programs, but that was not the case. That may be a cause for discomfort for instructors, simulation techs, and poor learner experience. Based on this observation, we may want to encourage more formal training for staff, hoping that they may improve distance simulation quality and the experience for everyone. The training content was equally balanced between two major axes: theoretical training, teaching, and learning considerations, and technical skills for platform training for instructors, and more focus on technical side for simulation technicians. Those results give us the when, why, who, what for the training of staff prior to distance simulation. Future directions. We were thinking about, when we were going through the data, one thing occurred, and you heard about that, 60% of the people who were doing distance simulation before the lockdown, and there were many that did not have prior experience. The picture that emerged was one of people that had a lot of experience with simulation, kind of doing what we do and adapting, right? So it's like you've got these experts who took their knowledge and made it work. So how do we convert this scenario from going forward? We took what we knew and made it work, but we've now got a model, so it's the opposite of what we think. Like, we do this all the time, but we've really gotten good and adapted as we've needed to. So we need to make sure that we have a model going forward, so when these things happen again, that we're always prepared, because it's been going on for quite a while, and there's a good chance there may be something else down the road, and we always need to be prepared. And simulation is a model by which we can utilize. So some of the questions that came up is, what competencies would be ideal for implementing distance simulation for faculty and staff? What types of training could be best used for faculty and staff development in order to optimize distance simulation? And what outcome measurements would be the most useful for determining future uses directions for distance simulation? So for our future, some of the things that we're looking at the summit. We did the summit, the scoping review, and the survey phase 2, which is happening, scoping review and consensus meeting. And we're going to do more work, and we are planning on getting folks together at the 2023 SSH Research Summit to discuss even more opportunities that have been identified. So speaking of IMSH, hopefully we're going to see you all at as many as we can see under the circumstances, because of the recent changes with the Omicron and travel restrictions. Hopefully people who cannot join us in person, we're looking at this point, over 1,500 folks have already signed up. We have, I believe, over 100 people join us virtually for IMSH, which our theme is appropriately reunite, connect, and advance. It's January 15th to the 19th. If you're interested in getting more information, there is a link here for you and like I said, we're so very excited about us having the opportunity to see each other again soon. So remember, this is some of the information you can find on our website, which is ssih.org. We have our journal, we have our dictionary, and our code of ethics, which have been, as you know, translated in multiple languages. We are incredibly appreciative of all of our affiliates who have helped us along the way to ensure that we have the latest and greatest for our members. So here's my contact information. I very much appreciate you having taken a few minutes, learning a little bit about some of the activities within SSH in the field related to these very challenging times. That's my contact information. And if you have any further questions or comments, feel free to contact me. Thank you again for your time.